Welcome to Vasopressors, Inotropes, and Antiarrhythmic agents. These are all cardiac drugs and are based on Rao's Respiratory Care Pharmacology, Chapter 21. Let's look at the cardiovascular system. The cardiovascular system regulates blood flow to various parts of the body. Blood flow generally travels via a pressure gradient, shifting from areas of higher pressure to areas of lower pressure. The central nervous system relays electrical impulses through sensory receptors found throughout the vessels. These receptors affect vascular tone and can cause shunting of blood from one area to various organ systems within the body. Vascular tone is regulated via the sympathetic nervous system and the circulation of neurotransmitters and hormones like epinephrine, vasopressin, and angiotensin. Several factors exert an effect on vascular tone as a response to tissue perfusion and circulatory volume. Hypotension is present in patients with autonomic dysfunction and shock. Shock is a life-threatening medical emergency characterized by organ hypoperfusion leading to decreased delivery of oxygen and nutrients to tissues throughout the body. There are four main types of shock, with several other categories of shock within those types of shock. We'll look at those now. Types of shock. Hypovolemic shock is the most common and is due to blood loss. This can be through hemorrhage or vomiting and severe vomiting and diarrhea. Neurogenic shock is shock that affects the central nervous system. Cardiogenic shock affects the heart, how fast it beats and how well it beats. Septic shock is the most common of the distributive shocks. In septic shock, there is an overwhelming infection that the immune system can't deal with. Let's look at factors that affect blood pressure and define some terms. Systolic blood pressure, or SBP, is the peak pressure reached during ventricular ejection. Diastolic blood pressure, or DBP, is the lowest pressure reached right before the ventricle ejects. Mean arterial pressure. Mean arterial pressure refers to the pressure that drives blood into tissues averaged over the entire cardiac cycle. However, the cardiac cycle is pulsatile rather than continuous, and 2/3 of the normal cardiac cycle are spent in diastole. Because of this, you can calculate MAP by 2 times the diastolic blood pressure plus the systolic blood pressure divided by 3. MAP can also be calculated as cardiac output and systemic vascular times systemic vascular resistance. But we need to define what cardiac output is. Cardiac output is the amount of blood leaving the heart with each contraction of the heart per unit of time. So, heart rate times stroke volume is cardiac output. MAP can also be calculated by Due to this, MAP can also be calculated by heart rate times stroke volume times systemic vascular resistance. Pulmonary artery catheters. Pulmonary artery catheters are important in managing hypovolemia or shock. PCWP, or pulmonary capillary wedge pressure, central venous pressure, or preload, can all be measured indirectly using a device called a pulmonary artery catheter. This measures the amount of fluid returning to the heart. With measuring the amount of fluid returning to the heart, the clinician can evaluate patients' specific response to fluid therapy and to vasoactive drugs. The use of the pulmonary artery catheter is associated with complications such as infection, pneumothorax, bleeding, and thrombosis formation because it is an invasive procedure. Cardiac drugs are used to influence cardiac function and include drugs that increase myocardial contractility, regulate dysrhythmias, and treat cardiac arrest. We're going to start with drugs used in the management of shock. Catecholamines. Norepinephrine or Levophed and epinephrine, adrenaline chloride, are endogenous catecholamines that are secreted by the adrenal medulla. These neurotransmitters travel to sympathetic nerve endings where they are released to stimulate other nerve fibers and stimulate an excitatory response. Norepinephrine and epinephrine stimulate alpha receptors within the blood vessels and beta receptors within the vasculature and the myocardium. Alpha receptors within the vascular cause vasoconstriction, whereas beta receptors cause vasodilation. Most vascular beds within the body contain beta receptors. However, they are far outnumbered by the number of alpha receptors. So epinephrine and norepinephrine stimulation of beta receptors is almost of no effect. This results in vasoconstriction. And it can also lead to tachycardia. Let's talk a little about isoprel. Isoprel has been around a long time and used way back in the 1960s used to be used as a beta adrenergic stimuli for bronchodilation of the lungs. However, it's not used that way anymore. It is used for treatment of shock because it's like taking a hammer and hitting the heart. It's used in the treatment of symptomatic bradycardia or torsades de pointes. It works solely as an agonist of beta receptors, and it has both inotropic effect, how strong the contraction is, and chronotropic effect, speeding it up, how fast. There's limited use though because it is so good at speeding up the heart rate. Dopamine. Dopamine directly stimulates beta receptors. There are both chronotropic and ionotropic effects. leading to increased cardiac output. That means both the strength of the heart contraction and how fast the heart contracts will lead to increased cardiac output. It stimulates peripheral alpha receptors, causing an increased systemic vascular resistance. At doses that are often required for patients in septic shock, high-dose dopamine, there is an increased risk of tachyarrhythmias compared with the risk of other vasopressors. Consequently, updated 2012 Surviving Sepsis Guidelines recommend the use of dopamine to be limited to highly selected patients, those with low risk of tachyarrhythmia or profound bradycardia. Overall, norepinephrine is considered a more potent vasopressor than dopamine and should be used as an initial therapy over dopamine in the setting of septic shock. Phenylephrine. Phenylephrine is a purely alpha agonist, yet it differs from epinephrine only in that it lacks one hydroxyl group on the benzene ring. So what does this really mean? It means that phenylephrine induces vasoconstriction in most of the vascular beds, elevating both systolic and diastolic blood pressure. Phenylephrine exerts an effect on systemic blood pressure by elevating total peripheral resistance. Due to unopposed alpha-1 stimulation, there can be reflex bradycardia when you are infusing this. This effect can be useful in patients who develop tachyarrhythmia while taking norepinephrine. Initial phenylephrine infusions are usually started at 5 mics per kilogram per minute. And similar to other vasopressors, rates can be titrated higher as needed to maintain the targeted blood pressure using this phenylephrine. Vasopressin is something that you'll see often in ICU settings. It's used in septic shock and is a naturally occurring hormone. It should not be used as a sole agent for hypotension when patients are septic. It should be used when other vasopressors like dopamine or epinephrine are not enough. Let's talk about protamine. Proamine is an oral inactive prodrug that converts to the active species once ingested. It is an alpha-1 agonist. It's indicated for the management of orthostatic hypotension. However, because midodrine can cause significant hypertension and reflex bradycardia, it should only be used in patients with orthostatic hypotension that is refractory to treatment with other drugs and severe enough to impair daily living. This is also noted as a U.S. Food and Drug Administration or FDA boxed warning, so called for the box surrounding the warning located in the manufacturer's information sheet or package insert in the product labeling. It can be used to wean patients from IV vasopressin. Let's talk about angiotensin II. This is an approved vasoconstrictor to increase blood pressure in adult patients with septic or other distributive shock. A central line should be used and is preferred, as with all vasopressors, to minimize the risk of extravasation. Extravasation is pain, swelling, erythema, blistering, blanching, or mottling of the skin, and it usually comes from administering a vasopressor with a peripheral IV. Risk of extravasation is much more likely with a peripheral IV. To reduce the risk of extravasation with vasopressors, a central line should be used. These are pictures of reactions to vasopressors administered with a peripheral line. Let's talk about drugs that increase the strength of cardiac contractions. Some of those drugs are dobutamine, phosphodiesterase inhibitor, and cardiac glycosides. We'll talk about dobutamine or Dobutrex first. This is used for short-term treatment of heart failure secondary to depressed contractility. Heart's not pumping well enough. It is a synthetic catecholamine and it's related to dopamine. It is not metabolized to norepinephrine. It does not stimulate dopamine receptors. It's an R isomer that causes positive ionotropic and chronotropic effects and vasodilates as well. Some adverse effects include tachycardia, hypotension, and increased myocardial oxygen demand. Phosphodiesterase inhibitors like Ionocore and Primacor inhibit intracellular phosphodiesterase. Murilinone has a shorter half-life than ionurone. It should be given with an initial bolus of 50 micrograms per kilogram over 10 minutes, or it can be given as an infusion of 0.375 to 0.75 micrograms per kilogram per minute. The dose should be adjusted in patients with severe cardiac failure or renal impairment. Digoxin. Digoxin is used to manage chronic heart failure. It has an ionotropic effect on the myocardium, or a strengthening of the contraction. It reversibly inhibits the sodium-potassium ATPase pump in cardiac muscle and inhibits the vagus nerve. Generally, there are no hypotensive effects. However, it has a very narrow therapeutic range, 0.5 to 2 nanograms per milliliter. Digitalis toxicity symptoms include nausea, vomiting, anorexia, and pain. It's eliminated by the kidney and is considered a cardiac glycoside. Let's talk a little bit about the electrical activity of the heart. Electrical activity is initiated in the SA node. Electrical potential exists across the cell membrane, and it changes in response to transmembrane movement of sodium, potassium, calcium, and chloride ions. These ions mediate the process of myocardial contraction, heart contraction, and relaxation. When an electrical stimulus is evoked from the SA node, it generates an action potential. Once generated, the action potential produces a local current and evokes further action potentials along the myocardium. An action potential elicits myocardial depolarization or contraction. The link between the atrial depolarization and the ventricular depolarization is known as the AV node. The AV node slows down the electrical impulse to ensure that atrial excitation is complete before ventricular excitation. After leaving the AV node, the impulse travels to the wall between the two ventricles along the conducting system fibers known as the bundle of His. From the bundle of His, the cardiac conduction bifurcates into three main bundle branches, the right bundle and two left bundles. These bundle branches form a conduction network known as Purkinje fibers. The conduction system innervates the myocardium and causes changes in membrane polarization along the muscle fiber. And here you can see the SA node going out to both atriums, the AV node where it will slow down the action potential and then pass it along to the ventricles, down the bundle of His to the left and right bundle branches. Let's talk about the different phases of when this happens. Phase 0 is an initial rapid depolarization of myocardial or heart tissues due to an abrupt transmembrane influx of sodium through fast sodium channels. So sodium rushes in through these fast sodium channels. In phase 1, the fast sodium channels are then inactivated. This, coupled with the movement of potassium and chloride ions, leads to transient net outward current at the beginning of repolarization. Phase 2 is a plateau phase. It's maintained by a balance between calcium coming in and potassium going out. And in phase 3, the calcium channels close, but the membrane remains permeable to potassium, resulting in cellular repolarization. In phase 4, the cell returns to its resting state. Resting membrane potential is reached through gradual depolarization related to constant sodium influx, balanced by decreasing outpouring of potassium. So this shows how a sodium-potassium pump works. You can see in this first picture that sodium ions are binding to the protein pump. In this second one, a change of shape occurs. In the third, the change of shape discharges sodium out of the cell, and then potassium can bind to the pump. Here, you can see that potassium is released and the pump returns to its original form. And the cycle repeats again. Let's talk a little bit about ablation therapy. Catheter ablation is very effective when atrial fibrillation is caused by a single aberrant cell. The procedure involves inserting a catheter into a blood vessel in the groin or the neck and guiding it towards the heart. When the tip of the catheter is placed against the part of the heart causing the problem, radiofrequency electrical current is applied through the catheter to produce a very small burn, about 6 to 8 millimeters in diameter. Patients need to be adequately anticoagulated at least 1 month prior to ablation to prevent formation of thrombi in the atria. The procedure carries a success rate in maintaining sinus rhythm over the next year of 30 to 90%. Let's also talk about implantable cardioverter defibrillators, or ICDs. These are used to cardiovert or terminate ventricular tachycardia and pace bradycardia. They're indicated for cardiac arrest secondary to ventricular fibrillation that is not reversible or transient. Spontaneous ventricular tachycardia and syncope due to ventricular tachycardia or ventricular fibrillation with no drug tolerance. Non-sustained ventricular tachycardia and coronary artery disease, myocardial infarction, and left ventricular dysfunction. This is generally used when drug therapy is not enough. There is a 40 to 70% of patients with ICDs require antiarrhythmic drug therapy. Antiarrhythmic agents are classified into groups on the basis of their electrophysiologic action. Class 1 agents depress the inward sodium current and are subdivided further as 1A, 1B, or 1C. 1A blocks fast sodium channels in the atrium and blocks the repolarizing potassium currents. 1B actions are limited to ventricular arrhythmias, and Class 1C commonly are used in the management of supraventricular arrhythmias, like supraventricular tach, but they have activity as well against ventricular arrhythmias. Class 2. Class 2 Class 2 agents are beta-blocking agents. They are used in the management of hypertension and post-myocardial infarction. Class 3 agents have complex effects that can prolong the action potential and in some cases exert beta-blocking action. They're used to treat supraventricular and ventricular arrhythmias. Class 4. Class 4 agents are calcium channel blockers. They're used in the management of supraventricular arrhythmias and ventricular rate control for atrial fibrillation. Other antiarrhythmic agents include adenosine, which is used to convert supraventricular tachycardia, or SVT, into a sinus rhythm. So let's start with Class 1. We'll start with quinidine. It's used for atrial fibrillation and atrial flutter. It's a rate controlling agent, but should be used cautiously in asthma, muscle weakness, or in the case of fever. Overdose symptoms include respiratory depression, vomiting, diarrhea, seizures, hypotension, syncope, and EKG change. Procainamide. Procainamide is indicated for the treatment of ventricular tachycardia, pictured here, and torsades de pointes, pictured here in the bottom. It has a pro-arrhythmic effect and may produce leukopenia or agranulocytosis. Adverse effects include lupus erythematosus-like syndrome. Norpace. Norpace is indicated for life-threatening ventricular tachycardia and paroxysmal supraventricular tachycardia. It should be initiated at the hospital. It has negative inotropic effects and anticholinergic side effects. Potassium should be corrected before initiation of this therapy. Class 1B agents are often used and have less pro-arrhythmic potentials compared with Class 1A agents. The Class 1B agents are limited to ventricular arrhythmias. Let's talk about lidocaine first. Lidocaine is frequently used to treat ventricular arrhythmia occurring during cardiac surgery or after an acute MI. After administering an IV bolus, due to the short half-life, continuous infusion is necessary to maintain a sinus rhythm. Lidocaine is metabolized in the liver However, some of the metabolites display anti-arrhythmogenic properties but are also highly prone to seizure activity. Patients need to be monitored vigilantly for signs of seizure, such as tremors. Other side effects include insomnia, drowsiness, ataxia, agitation, and dysrhythmia. Mexilentine. Mexilentine has a mechanism of action similar to lidocaine and is available as an oral formulation. It's indicated for the treatment of life-threatening ventricular arrhythmias. However, because of its anesthetic properties, it is also used at a lower dose to reduce neuropathic pain associated with diabetic neuropathy. Large overdoses can cause coma and respiratory arrest. However, usually GI disturbances, tremors, lightheadedness, difficulty in coordination, dyspnea, and respiratory problems are the most common side effects. Ventricular premature depolarizations, monomorphic ventricular tach, and polymorphic ventricular tach and VFib are some of the ventricular arrhythmias. Procainamide is an oral form of lidocaine. It's used to treat ventricular arrhythmias, myotonic dystrophy, and trigeminal neuralgia. It carries a box warning because of its pulmonary side effects. It can cause pulmonary disorders like pulmonary edema and respiratory arrest. Pulmonary edema, fibrosing alveolitis, pneumonitis, respiratory arrest, and blood dyscrasias are some of the reasons for this boxed warning. Class 1C. It's generally not used due to the high pro-arrhythmic potential. However, it may be used in some instances for supraventricular or ventricular arrhythmias. Class 1C includes Tambacor. This is indicated for the prevention of paroxysmal atrial fibrillation and paroxysmal supraventricular tach and sustained VTach. It has a long half-life and is shown to contribute to excessive mortality and non-fatal cardiac arrest. It's cleared in the kidneys by urinary pH. An acidic pH increases clearance. An alkaline pH decreases clearance. Pill-in-the-pocket approach has been shown to be successful. The pill-in-the-pocket approach is an alternative treatment of recurrent arrhythmias in which a pill is taken by the patient at the time of onset of palpitations. Rhythmol. Rhythmol prevents PSVT and sustains normal sinus rhythm post-cardioversion. It's a first-line agent for recent onset atrial fibrillation and is a non-selective beta blocker. However, you need to use caution in patients with bronchospasm. Beta blockers, Class 2. Class 2 agents consist mainly of the beta-blocking agents. These agents are used in the management of hypertension and post-myocardial infarction status. Metoprolol is the only agent in this class that can be used in the setting of CHF. Beta blockers should be used with caution in patients with pulmonary disease, especially non-specific beta blockers, as they can have an effect on beta agonists used to treat asthma, chronic obstructive pulmonary disease. Examples of beta blockers include Enderol and Lopressor, as well as Tenormin and Corgard. These should not be used in acute heart failure. Amiodarone. Amiodarone is effective in the management of ventricular arrhythmias and supraventricular arrhythmias. In the past, life-threatening adverse effects of amiodarone prevented it from being used as a first-line agent. It was reversed for patients with life-threatening ventricular dysrhythmias. Amiodarone seems to exhibit greater efficacy and a lower incidence of pro-arrhythmic effects than class 1 or 3 antiarrhythmics. Today, amiodarone has become a mainstay in the management of atrial fib, ventricular fib, and ventricular tachycardia. However, amiodarone-induced pulmonary toxicity warrants care when treating patients with arrhythmias. The main caveat associated with amiodarone is its distinctive side effect profile. Baseline parameters that must be obtained before starting therapy, along with incidences of various side effects, are in your book in Table 21.7, and I suggest that you review that. Pulmonary toxicity is one common effect and is evidenced by cough and by local or diffuse infiltrates on chest X-ray. It occurs about 20% of the time. Amiodarone may also interact with prescription, herbal, and over-the-counter medication. Class 3. Multac. Multac has a chemical structure like amiodarone. It has reduced toxicities of the thyroid gland and reduces risk for hospitalization in patients with paroxysmal or persistent atrial fibrillation or flutter who are currently in normal sinus rhythm or pending cardioversion. It's given orally and contraindicated when there is potent CYP3A4 inhibitors and inducers. Amiodarone is considered more effective in the management of chronic atrial fibrillation. Tikecin. Tikecin is an oral formulation and used in the maintenance of normal sinus rhythm after cardioversion. It's ineffective in paroxysmal atrial fib, and there is significant risk for ventricular arrhythmias, mostly among females, chronic heart disease patients with diminished renal function, and doses that exceed 500 milligrams twice a day. Treatment needs to begin with inpatient monitoring. Prescriber and pharmacy must be in the TICASIN pharmacy system. Betapace and Betapace extended release formula. This is an oral medication that prolongs action potential and has a relative refractory period. It's used for ventricular and supraventricular arrhythmias. It requires 3-day inpatient monitoring, and caution should be used when treating patient with restrictive airways disease like COPD and asthma. Covert. Covert is an IV drug. It's an alternative to electrical cardioversion and indicated for rapid conversion of recent onset atrial fib and atrial flutter. The patient cannot have any other Class 1 or Class 3 medications within the last 4 hours, and patients should be adequately anticoagulated before administration. Let's talk about calcium channel blockers. Like verapamil and cardiazem. They're used in the management of supraventricular arrhythmias and ventricular rate control. They block calcium channels in the AV node and are a good alternative to beta blockers. However, they are not favorable in chronic heart failure. Digoxin. Digoxin has direct AV blocking effects and vagotonic properties that aid in reducing the heart rate. Although digoxin prolongs the relative refractory period of the AV node and reduces the number of impulses through the AV node, it is not regarded as a first-line agent for atrial fib. Digoxin does not have a rapid onset, especially when you're trying to manage an acute condition such as atrial fib. It requires about 2 hours to achieve its maximum effect. Also, digoxin has the potential to shorten the refractory period of atrial muscles, allowing electrical impulses to be conducted throughout the myocardium and ultimately potentiating episodes of atrial fib. It's less effective than beta blockers and calcium channel blockers during states of increased sympathetic tone, like exercise and stress. Digoxin is not regarded as a first-line agent for the control of ventricular rate in AFib, except in patients with impaired left ventricular function or heart failure. Adenosine. Not to be confused with amiodarone. Make sure they're very different. Adenosine is used to terminate supraventricular tachycardia. It has a super short 12-second half-life and should be given with a central or brachial line with the arm held up. There has to be a flush immediately. Side effects include bronchospasm, dyspnea, increased respiratory rate, and cough. Sudden cardiac death. Death from heart disease is the leading cause of death in the United States, and 3/4 of these deaths are caused by sudden cardiac disease. Sudden cardiac disease can be defined as an episode of VFib, pulseless VTAC, pulseless electrical activity PEA, or asystole, all of which are life-threatening arrhythmias. Although fatalities associated with episodes of SCD are unacceptably high, an individual may be resuscitated, and it is common to encounter patients having a history of sudden cardiac death. The goal in treating sudden cardiac death is to restore sinus rhythm and prevent further episodes of sudden cardiac death, and prevent impairment of the brain function. How do we do this? When CPR is initiated, the decline in survival occurs at a more gradual rate of approximately 3 to 4% for every minute between the onset of symptoms and the time to defibrillation. Needless to say, efficient and timely delivery of defibrillation and CPR is imperative for successful management of sudden cardiac death. Epinephrine. Epinephrine is an endogenous neurotransmitter and is admitted in 1 milligram doses as a 10 ml solution. Epinephrine stimulates beta-1 adrenergic and beta-2 adrenergic receptors, which are found in dense proportions in the heart and lungs. The effect of epinephrine on the alpha-1 receptors located within the coronary and cerebral vasculature is more closely correlated with efficacy. Stimulation of the alpha-1 receptors causes vasoconstriction of the coronary and cerebral vasculature, increasing blood flow to the heart's myocardium and the central nervous system. When using epinephrine, there may be decreased receptor affinity in the setting of metabolic acidosis. Metabolic acidosis may readily ensue during sudden cardiac death because of hypoxic conditions leading to a shift in anaerobic respiration. At the present time, there is no recommended maximal dose of epinephrine in the management of sudden cardiac death. Post-resuscitation side effects include hypertension and tachycardia. Vasopressin. Vasopressin is also known as an antidiuretic hormone. It is an endogenous hormone that acts as a potent vasoconstrictor. Before 2015, vasopressin was administered as a one-time IV dose of 40 units. Because the effects of vasopressin have not been shown to be exceedingly different from the effects of epinephrine, this dose was to be administered in lieu of the first or second dose of epinephrine when treating any form of sudden cardiac death. However, more recently, vasopressin was removed from the algorithm because of the lack of benefit over epinephrine. It is a non-adrenergic and has the affinity is not compromised in the face of metabolic acidosis like epinephrine. Atropine or atropine is used for bradycardia. Atropine or atropine is indicated for certain forms of sudden cardiac death, such as asystole or PEA, usually given at a dose of 1 milligram IV push, along with epinephrine or vasopressin. Atropine acts by blocking the actions of acetylcholine. The cholinergic system is typically involved in heart rate reduction, and by blocking this effect, atropine exerts a pronounced, though short-lived, chronotropic effect on the heart. The recommended maximal dose of atropine used during resuscitation is 0.04 milligrams per kilogram. Because atropine affects acetylcholine globally within the body, there are noticeable adverse effects, including dry mouth, urinary retention, and constipation. Sodium bicarbonate. Sodium bicarbonate is routinely and frequently used for the management of metabolic acidosis. It's indicated in a variety of settings that may induce acidemia, including metabolic acidosis from severe renal disease, shock, cardiac arrest, uncontrolled diabetes, ECMO, severe diarrhea, and certain drug intoxications such as tricyclic antidepressants, barbiturates, and aspirin. Sodium bicarbonate infusions are not recommended in septic patients unless acidosis is severe. It can and will increase CO2 levels and should be used in caution with known CO2 retainer. Meg sulfate. Meg sulfate is used specifically in the case of torsades de pointe, pictured here. The dose is 1 to 2 grams and may be repeated after several minutes. Caution should be used in patients with kidney disease, and magnesium toxicity may result. You could see sweating, hypotension, hypothermia, reflex depression, and CNS depression, respiratory paralysis, circulatory collapse, or flaccid paralysis. Let's talk about some routes, alternative routes of administration for some of these drugs. They can be being given in a long bone. The intraosseous route is recommended for use in children and adults that are peripherally shut down. It can be used when IV access is lost or too hard to gain, like in infants, children, the elderly, or IV drug abusers. The needle should not remain in for more than 3 to 4 hours and should be secured. Endotracheal administration is used when intravenous route is not accessible, nor are you able to put in an intraosseous route. Naval or naloxone, atropine, vasopressin, epinephrine, and lidocaine can all be given by the ET tube. You need to give a double dose and dilute with 10 milliliters of normal saline. It works best when the ET tube is already in place, and then follow the distillation of the drug with 5 to 10 rapid ventilations. This is not the preferred route of administration. Thank you. This is the end. Please let me know if you have any questions or concerns.